version. Okay, now we have Bud Burnett. Hello there. Can you hear us?
I can hear you.
Hi, Bud. Thank
I didn't
you.
get off the mute. I had myself silenced.
Really? Okay. So thank you for being with us. And but is another person. Is like David Barron. He gives like 4 or 5 conferences in the whole meeting. Now he could not be with us present, which we wish it was impossible. He is available anytime we want, and that I so appreciate it. Let's go.
Okay, I'll get started. Ingrid, again, you're so wonderful. You are just a wonderful person, wonderful colleague. And again, thank you for having me. And again, I apologize to everyone there that I'm not able to be with you at the moment because I just have so many other activities that have interfered. But let me pull up my presentation and we'll get started. So give me just a moment. I hope you're hearing me okay. Okay, well, just to move forward here. In the next 20 minutes, I just want to share with you a presentation here on how we're advancing the management of erectile dysfunction. Again, thank you for your patience. And again, I certainly have the advantage here of being involved with some of the society guidelines. I've been a surgeon scientist for many years. I've been very involved with the science of erections. So thank you for allowing me to share with you my thoughts. Here's some disclosures. What I'd like to do is describe to you where we think we're going with erectile dysfunction management. And that has to do with, I think, understanding the science as we describe the various targets that we can direct our therapies based on. And I think we're moving more towards the concept of restorative therapies with some exciting new developments that I'll share with you. Now, this is the process of care guidelines that basically refer to how we think about management along the lines of first, second, and third line treatments, having to do with the ease of administration of the options and their level of invasiveness. Certainly, we all understand that first line oral pills and counseling are least invasive, maybe easy to administer, and then to the far right side, surgery, which is much more invasive and requires perhaps some surgical expertise there. In between are second line non-surgical options, vacuum pump, penile injections, and also intraurethral suppositories. Now, guidelines that have come about in the past several years include the AUA guidelines and other guidelines as well. I was privileged to be the chairman of the AUA guidelines on erectile dysfunction that we published several years ago. And this guideline did acknowledge that in the setting of personalized care or patient-centered care, we wanted to recognize that the patient and partner are involved in the decision-making process. We've used the term shared decision-making, and the framework there is being shown on the slide in terms of all the options being put on the table. And you see the middle of the slide, and all options then can be presented to the patient and based on patient value systems, their preferences, their understanding of their sexual behaviors and orientations and interests. We may judge the best intervention that achieves the best success while also balancing that against potential side effects. And then at the bottom of the slide, making the point that patients can be reevaluated and explore other treatment options if needed. Now, the new science of sexual medicine is, I think, to really understand more about the science, the cellular, the molecular mechanisms, understand the physiology of erections, and then develop therapies based on that. And I think there are some new perspectives on ideal therapy. The old paradigm was basically to treat erectile dysfunction, oftentimes with repetitive and momentary interventions that did not really correct the problem, and options included pharmacotherapy and devices. The new paradigm is to look more towards how we can correct erectile dysfunction with a more sustained benefit of how we achieve this and new ideas that are going to emerge, I think, along those lines. And I think this is really the new direction we need to be thinking about. There are a variety of targets and technologies that range from various new drug therapies all the way up to devices. And all of this is very exciting. I'm going to walk through a few of these just to give you my perspective. But again, the purpose here is to consider whether we can really revitalize or reconstitute penile erectile tissues and achieve kind of, if you will, a functionally intact state in the face of injury or disease. Now, I think we've learned a great deal over the years about some of the mechanisms of erection at the peripheral level. And we know there are a variety of mechanisms involved, variety of factors. Nitric oxide is central, and that drives a mechanism that we've been able to exploit already with PDE5 inhibitors, based on the mechanism by which nitric oxide drives the erection response through a second mediator, uh, which is cyclic GMP, and its degradation involves PDE5. And if we can actually interfere with that mechanism that controls the erection response, then we can promote the erection effect. Now, the key on this is much like we think about many mechanisms in the body, there's factors that drive a response and also factors that inhibit a response. And so the contractile side also remains exciting to think about. Much of this, as you can see on the right side of the slide, may converge with the rho kinase pathway. And I think we're trying to explore various ways in which we can exploit much of these anti-erectile mechanisms potentially going forward. Also exciting is thinking about the central nervous system. The central nervous system offers a variety of potential mechanisms as well. A bit more challenging to experimentally determine what's in play, but I list here a whole host of factors. Some new and exciting ones are cannabinoids, some of the endogenous vascular growth factors and growth factor secretagogues. And I'm going to speak about some of these. And some of these do operate at a central level. The key is how can we drive the responses without having side effects? And of course, very challenging for us to put forward new interventions. This is a slide that just tells you that there are a host of different ways we can move forward along the lines of nerve protection. And this is very germane to what we're doing, I think, in the area of prostate cancer surgeries, thinking about new ideas here by which we can not only just physically preserve the nerves by doing the very best surgeries we can do as surgeons, but also consider how do these nerves heal? What are their nerve regenerative potentials, and what are the factors involved? And I think this just makes the point that there are a whole host of therapies that I think are being studied in the field. No need for me to walk through all of these, but hopefully you have a glimpse of this from the slide. In terms of nerve regeneration, there are also concepts that also range from various neurotrophic factors to various ways in which we think we may be able to drive nerve function. And these include tissue engineering and even nerve stimulation. And very exciting in our field are some new exciting things that are being done with implantable nerve stimulators in the pelvic region. My laboratory and my collaborative group is working a great deal on some of this lately, with some early evidence that this may be beneficial. But the idea here that we need to understand the science, and perhaps we can drive not just protection, but also regeneration. Okay, sorry, the slide was not advancing. I just put together here just kind of maybe a way of combining the thought processes here of how we may eventually have to think about a variety of factors that may have to be brought together. We have also done in our basic science work just individual agents that we think may have benefits. But I think that at the same time, as we think about the range of factors that are both promoters and inhibitors of erectile function recovery, particularly in the setting of cavernous nerve injury at the time of prostate surgeries, we may actually then think about combined therapies that may work through mechanisms that achieve the best erection response. Again, this gets back to the paradigm of what are pro-erectile and anti-erectile mechanisms at different levels, and then exploiting that basic concept. Now, growth factors, I think, are targets for erectile dysfunction in terms of thinking about the variety of factors that are involved, and this can occur again on the level of nerves, but also on the level of the vasculature. And I think it's very exciting to think about the potential directions that many investigators have been working on over the years. I just wanted to show you here that much of this work involves a host of investigators that we should congratulate, working on a variety of genes and proteins, animal models, and showing that there's potential impact for nerve regeneration, as well as angiogenesis or vascular function recovery, and various models that suggest some potential benefit. So again, we may come to determine that there really is a synergism of a variety of agents and combined therapies that may be most beneficial. And I also talk about anti-fibrosis because I think that is, a certain condition whereby the penile tissue becomes less functional over time. And if we can work in the direction of understanding the science of tissue fibrosis, not just in the worst settings of tissue damage from diabetes and maybe post-surgical infections with prosthetics and so forth, but really thinking about ways in which we can preserve the general well-being of the erectile tissue. Those also will be exciting directions for the future. A brief word about stem cells. This has been a great deal of excitement over the years, and there are a variety of potential directions this goes in terms of what factors here liberate substances that have a potential to drive mechanisms. That basically is the concept. It may not necessarily be just the stem cells themselves. It may be what the stem cells produce and how these factors that are released from stem cells play a role. We have a host of different directions we can go in that suggest that there are progenitor cells and cells at different tissue locations in the body that might be obtained, harvested, and produced in such a way that they can produce stem cells for use. And this has been done largely on animal levels with evidence that these sort of studies do have both evidence of driving molecular factors, but also having functional benefits that we've been able to study in rat models of penile erection. So again, just a glimpse of this, really, that this area, I think, is going forward. Clinical trials still remain somewhat limited, however, and by way of summary, to get to the human level, we've struggled still to bring forward the best therapies that we've done, at least on the animal level. And so at this time, I would have to say that the future still looks bright, but we don't have any, to my knowledge, well-established evidence of what will be brought forward just yet. I think a concept that I'd like to share with you is how we think again of the concept of the severity of the erectile dysfunction, the degree of tissue dysfunction or damage or replacement that's required. I'm borrowing this from George Christ, who several years ago promoted the idea that we may bring regenerative medicine forward, along with various other ways in which we restore tissue function and tissue structure, from stem cells, genes, proteins, and even tissue engineering, depending upon the severity of the problem. Now, shock therapy, we've all been excited about over recent years. And I think at this stage, much of our society guidelines are still suggesting that we need to study this field even better. The idea here is the mechanical induction of various factors based on the principle of tissue stimulation in a way. It's been studied in a variety of disciplines, as shown on the slide here, and has shown some benefit in terms of tissue healing and tissue benefits. I just show you here a protocol. The challenge in our field is there are different protocols, different models, different shockwave instruments, and I think we still need to be more critical about how well we're developing these therapies and how much they're coming forward to be beneficial. This was a meta-analysis that my group did several years ago. I think by and large, many have done similar sorts of studies that suggest there may be some potential for improvement, and seemingly no adverse events. But we need to continue to study in this field to show who are the best candidates for therapy, who will have the best responses. And from my perspective, considerations include continuing to do the right kinds of studies with randomized controlled trials longer term follow up, we do see some potential for short term benefit. Can we actually produce long term benefit? We need to establish how we go about reporting of data to be consistent and be able to compare the studies and understand really how to comprehend all of it across different studies. Understand how we go about protocols to achieve the best dose dependency and a treatment schedule that would be well established. The mechanism of effect, it remains unclear, and exactly what is the mechanism by which erectile tissue is responding and behaving awaits further scientific work. And again, as I mentioned before, try to determine who is the best patient. What is the select population of ED patients? This also remains unclear and should be better defined. The idea of tissue engineering is terrific. Dr. Atala, I know, is with the meeting there. He and his group have been the leaders in all of this. And I just want to give a shout out to champion all that good work. Again, maybe for the more diseased condition, the notion of tissue reconstitution or replacement may be suggested by new ideas here. And I think this work dates back some time, but should continue from my perspective. So I'm going to conclude by saying that I think that our field of sexual medicine uh, and erectile dysfunction specifically is making advances. I think it's based on the science as we understand molecular and biological factors that relate to erectile dysfunction and erection physiology. I think we'll continue to advance the field. I think that the direction of the field is such that we're going beyond just treating erectile dysfunction, but instead trying to move toward restorative therapies, and I think the field is still very exciting and ripe for us to continue on with new options. So it's a little cartoon. Stop showing off. I know it's your walking stick. I do want to conclude here. I hope that I will stay within my time, and I do appreciate the audience for listening to my presentation. Thank you very much.